Hi, Katie. Can you share your screen and stuff now? I think I've made you a panelist. Lovely. So I if you want, when you're going through the questions, if you want to do polls and stuff, we've got them set up. So I can launch them if that's a bit easier for you. I can't hear you yet, so I don't know if your mic's on.
Oh, sorry, I was muted. That's hello. Do you mean polls like when we go through the answers? Oh yeah, that would be good. Oh, I think you're muted now.
Yeah, that was my bad. Yeah, we usually do it when we go through the answers just to like see how many people got whatever. So I can launch them.
That'd be good.
Cool, perfect. We will just wait for people to come. I think it's just us at the moment.
And people see me as well, just out of interest, or just
so currently I can't see you.
Yeah, I don't know if that's because I've not got my camera. Maybe it's because that's why it's because my camera's. Oh, it says it's been stopped by the host.
Okay, let me try.
I mean, I really don't mind if I'm not seen.
If I make you a host, now it might let you.
Oh yeah, there we go. Oh, there we go.
Perfect. Brilliant. Right, I'm gonna turn my stuff off just so I'm not distracting, but I'm around if you need anything.
So if they have questions, do they normally like ask them just at the end, or?
So the questions usually go in the question and answer box. What we usually do is if I know any of the answers, I'll try and answer them as we go along. And if I don't, I'll just wait until the end and then we can like go through anything that we've missed, or like if they want to go back over something, they'll usually put it in the Q&A.
Okay, cool. Sounds good.
But yeah, is that all?
And then the first, how long do they have to do the question, or will you go through explaining?
So usually when we do the like practice question, the practice mock at the start, we usually give between like a minute and 45 seconds, depending on how long the question is.
Okay, cool.
To go through all of the questions and then go through the answers like afterwards and can get like see what people have put for the answers.
Okay.
Does that make sense? But yeah, kind of however works best for you, but that seems to work well. I think people are slowly trickling in, but we'll give it a couple more minutes. I will just turn off my video. Cool. So Katie, feel free to start whenever you want to. I don't know whether people might start trickling in, but they can join in with the mock if they want.
Okay, so hi everyone. I'm Katie. I'm an F2 from Chester, and I'm going to be teaching this week about gynecology. So if you've not done one of the sessions before, there's going to be 15 like MCQ style questions to begin with. So we'll do like a timed mock exam, and you'll have like between 45 seconds to a minute for each question. Some of them are longer than others. So yeah, so is everyone happy to, well, I know you can't all answer me, but we'll get started then, I guess. I'll just like set a timer. Okay, so I'll start from now. Okay, everyone, so that's the end of the mock exam. So we'll go through the answers now. So question 1. So a 22-year-old nulliparous woman attends her GP complaining of heavy and painful periods and deep pelvic pain during sexual intercourse. Her period started when she was 9. She is a smoker. She can recall that her mum and aunt have experienced similar problems. On examination, mild generalized abdominal tenderness, no palpable abdominal or pelvic masses, normal speculum, and bimanual examination. So given the most likely diagnosis, which of the following investigations is considered the gold standard? So if you just put your answers on the poll in the Q&A box. Okay, so most of you guys got that right. So the correct answer was D. And so, yeah, as you probably gathered from the history, the diagnosis was endometriosis. So this condition is when basically endometrial tissue grows outside of the uterus. Risk factors include being nulliparous, so not having any children or not having had any childbirths, late menopause, early menarche, smoking, a family history, white ethnicity, a low BMI, and autoimmune disease. And common symptoms are cyclical abdominal and pelvic pain, deep pelvic pain during sexual intercourse, painful periods, reduced fertility, so patients may have difficulties getting pregnant, and if it's quite severe, they may also have urinary symptoms and painful bowel movements. So as we saw in the history in the question, the patient had menorrhagia, dysmenorrhea, dyspareunia. She had a few risk factors like smoker, family history. So that pointed to what the diagnosis would be. So the examination findings. So the patient in the question had a normal examination, but this doesn't exclude endometriosis. But some things you might find on examination include generalized abdominal tenderness, a fixed cervix on bimanual examination, and there may be some tenderness in the vagina, cervix, and adnexa. On the speculum exam, you may possibly see some endometrial tissue. But yeah, in most cases, there is a normal examination. So just moving on to the investigations. So as most of you guessed, laparoscopic surgery is the gold standard. So pelvic ultrasound sometimes are carried out, especially if it's not clear what the diagnosis is. A lot of the time they're normal, but sometimes if there's large endometriomas, which are basically clumps of endometrial tissue, and also known as chocolate cysts, you may sometimes see this on ultrasound. But yeah, laparoscopic surgery is the best way to diagnose it because you can directly see the tissue, and you can do a biopsy at the time to confirm that the tissue is endometrial tissue. And whilst you're doing that, you can basically treat the endometriosis by ablating the tissue and removing adhesions, but this doesn't cure it as it may grow back, but it will offer some short-term symptomatic relief. And then the other ones, a couple of people said transvaginal ultrasound, and one person says MRI, but they don't tend to show necessarily, they might show some things like the cysts and things, but as we said, the laparoscopy is gold standard. But most of the time it is a clinical diagnosis. And obviously we wouldn't be routinely in GP referring for laparoscopic surgery. So yeah, and then question 2. So a 19-year-old female presents to the GP with postcoital bleeding. During a speculum examination, you see the following. So the question is, which of the following is not a risk factor for this condition? Also, we've got a bit of a mix here. Some people might be changing their answers. Okay, so the majority have said A, and quite a lot have also said B, and some people have also said E, so there's quite a mix. So okay, I feel like I want to ask questions, but I feel like I'm talking to myself. But basically what this picture shows is a cervical ectropion.
Katie, if you want to ask any questions, I can keep an eye on the Q&A box if people
Oh,
want to put
fine,
their answers
okay.
in there.
Fine, I quite like sort of asking questions as I go, so I might do that. Thank you.
Yeah, go for it.
So I've just told you guys, but I was going to ask someone what the diagnosis is, but this is called a cervical ectropion. So, and in this case, it's presented with postcoital bleeding. And the correct answer, which is not a risk factor for this, is actually B. So all the other answers are actually risk factors. So I'll just explain quickly what a cervical ectropion is. So it's when the columnar epithelium of the endocervix extends out to the ectocervix, as you can see in the diagram here. And these columnar cells are more fragile and prone to bleeding, so that's why it often presents with postcoital bleeding. When you do a speculum exam, you might see the columnar epithelium has like a red appearance, and it's normally arranged in a ring around the external os, as you could see in the previous photo. And it's caused by high levels of estrogen. So anything that causes high levels of estrogen is a risk factor. So the combined oral contraceptive pill, pregnancy, menstruation, being of menstruating age, and being an adolescent means that you have high levels of estrogen. So these are all risk factors. Having multiple sexual partners would not increase your risk. It's completely like benign, quite a normal finding actually. So that's why it's quite important to be familiar with it. And as long as it's asymptomatic, it doesn't require any treatment. Generally, it will just go away as patients get older. And if they were on the pill, if they stopped taking the pill, it might also go. If they were symptomatic, if it was bothering them, like especially from the bleeding point of view, then you can ablate the endocervix, ablate the epithelium or cauterize it. So yeah, that's cervical ectropion. So moving on to question number 3. So a 39-year-old female is experiencing heavy periods lasting up to 10 days, as well as deep pelvic pain during sexual intercourse. She experiences bloating and abdominal pain, which is worse when she's on her period. She has 2 children and does not plan on having any more. The past medical history includes migraines, eczema, asthma, drug history, inhalers, and sumatriptan. On examination, bimanual examination reveals an enlarged non-tender uterus. On pelvic ultrasound, there are several large fibroids visible within the uterus. So which of the following treatments would be the most appropriate to help control her bleeding? Okay, so the majority, so about half of you have said the answer B. And quite a lot have also said E, tranexamic acid. So the correct answer is actually C. So there's a few little things in the history which are important to note. So we obviously know what the diagnosis is in this case because we can see that there are some large fibroids on the ultrasound. Her symptoms include menorrhagia, dyspareunia, bloating, abdominal pain. It says in history that she has got 2 children and doesn't plan on having any more, and she's also got a past medical history of migraines. So the majority of you have said the Mirena, which is in fact the first line for managing menorrhagia. However, the fibroids must be less than 3 centimeters with no distortion of the uterus. We've not actually said in the question how big the fibroids are, but we've said that they're large. So this is a possible contraindication, and the IUS is also, and as well as the combined pill, which was option A, are contraindicated if there's a history of migraine with aura due to the slight increased stroke risk. In all fairness, we've not actually said whether the migraines were with aura or not, so maybe that was my fault, because a lot of you did put B as the answer, which would have been correct if there wasn't these contraindications. Tranexamic acid would also be a good option to help reduce bleeding. However, this lady would need contraception because she doesn't want to have more children. So, and I don't know if we've said whether she's sexually active or not, but I guess we can assume she might be. Generally one of the contraceptives would be a better method. So the best would be the cyclical oral progesterone. So that would be something like norethistone, which you take from 5 to, say, for like part of the cycle and then have a break. The only downside to this is it increases VTE risk. So if patients did have any risk factors or family history of VTE or anything like that, I'd probably avoid that. But yeah, that was quite a tricky one, sorry. And maybe I didn't make it completely clear whether she had migraines with aura or how big the fibroids were, or whether she was sexually active. I've just put that she doesn't want any more children, but who knows? So yeah, so moving on. The next question was, after failed medical management, she'd like to consider surgical options. What medication may be given to help shrink the size of the fibroids prior to surgery? Okay, so The majority of you guys got this one right. So it is in fact goserelin. I don't know if I've said that correctly. Goserelin is a GnRH agonist, which suppresses ovulation, which induces a temporary menopausal state. And it's used pre-op to help reduce fibroid size and lower complications. It can only be used for short term, 6 months maximum, due to the risk of osteoporosis. The other, I think, to be honest, the majority of you said goserelin. The desogestrel is a progesterone only pill, so that's not going to help shrink the size. And tamoxifen is used in an estrogen receptor binder, which is used in breast cancer. And as we mentioned, tranexamic acid would be used to help control the bleeding, but it wouldn't shrink the fibroids. Other like medications which may be used, so we've talked about hormonal contraceptives and tranexamic acid. Otherwise, generally NSAIDs are used for the dysmenorrhea, so like mefenamic acid is first line for dysmenorrhea, not just in fibroids but in general. So just a bit on surgical options for managing fibroids. So for submucosal fibroids, hysteroscopy and transcervical resection may be used. Myomectomy, which is surgical removal of the fibroid, may be performed if it was a younger female who would want to preserve fertility. If they were done having children, then you could consider a hysterectomy, so removal of the whole uterus. Uterine artery embolization may also be used, which basically cuts off the blood supply to the fibroids, which cause them to shrink. And I've just done a little slide on what fibroids actually are, in case anyone didn't know, and where you get them. So they are benign smooth muscle tumors that arise from the myometrium of the uterus. As far as I can remember, the intramural are the most common type, and these are the fibroids that are actually confined to the myometrium. Submucosal fibroids you find underneath the endometrium of the uterus, and they will protrude into the uterine cavity. And finally, subserosal fibroids protrude into and distort the outer surface of the uterus, and they may have a stalk, as you can see in the photos in the diagram there. So quite a nice little diagram to help you visualize where the fibroids grow. So just quickly, risk factors include obesity, early menarche, increasing age. So I think this patient was like, I have to remind myself, 39. So that's quite common, women in their 30s and 40s. African Americans are 3 times more likely to develop fibroids as well, so that's something to bear in mind. Symptoms, as we've already kind of covered all this, but like menorrhagia, prolonged menstruation, so periods lasting more than 7 days, subfertility, difficulties getting pregnant, and bloating, abdominal pain, urinary and bowel symptoms, sometimes if they're really large fibroids due to the pelvic pressure and fullness, dyspareunia, so pain during sexual intercourse, investigations that may be done. So these are some that might be used. MRIs would normally only be done if the patient's going to be having surgery, so they can get a more detailed view. And a pelvic ultrasound is usually done as a first investigation to confirm the diagnosis. And hysteroscopies are generally done for the submucosal type, as we mentioned in the surgical management. Moving on to question 5. So a 26-year-old actually I think the question actually said 25, but anyway, 25, 26-year-old attends the GP for her first cervical smear test. The results show that the sample is positive for HPV, but there are no abnormal cells found. What is the most appropriate next step? So A, repeat the smear in 5 years, B, repeat the smear in 3 months, C, refer for colposcopy, D, repeat the smear in 12 months, or E, repeat the smear in 5 years. So I think majority of you guys got this right. So the correct answer is D. So repeat the smear in 12 months. That's correct, because she's positive for HPV, but there are no abnormal cells found. So just a bit about the cervical screening program. So obviously, as I'm sure you know, it's smear tests are carried out to detect abnormal cells in the cervix to help identify and prevent cervical cancer. Screening is done every 3 years for women aged 25 to 49 and every 5 years for women aged 50 to 64. And this slide just tells you how you interpret the smear results. So firstly, if there's an inadequate sample, you'd want to repeat the smear after 3 months. If they're HPV negative, then don't need to do anything, you just continue the routine screening. If they are HPV positive, you need to repeat the HPV test after 12 months, and that's if they've got normal cells. If they're HPV positive and they've got abnormal cells, then that's worrying. That's when you're worried about the risk of cancer, so you want to refer them for colposcopy so they can have a biopsy and things. Obviously, if on the smear test you see any worrying signs like ulceration of the cervix, it's significant inflammation, bleeding, a visible tumor, then you'd that would warrant an urgent cancer referral. So just a bit more about cervical cancer and how it might present. So generally it will present with, well, often we don't know it's there, which is the precancerous cells are there, which is why we do the screening. So ideally we would pick it up before it gets to this stage, but if it's not picked up on the smear, then it may present with abnormal vaginal bleeding, whether this is intermenstrual bleeding, postcoital bleeding, or postmenopausal bleeding. May also get vaginal discharge, pelvic pain, pain during sexual intercourse. Risk factors include smoking, HIV is another significant risk factor to be aware of. Their screening program is slightly different. I think, I can't remember what it is now, but they definitely have more regular smear tests. Increased number of full-term pregnancies and family history again. These all increase your risk. So moving on to question number 6. So a 62-year-old lady presents to her GP complaining of anorexia. Oh no, I've just given the answer away. Hopefully no one saw that. Anorexia, early satiety, abdominal bloating, and weight loss. Her CA-125 is 72. Given the most likely diagnosis, which of the following is not a risk factor for this condition? So yeah, the majority of you, 70% have got this correct. So early menopause is not a risk factor. And can anyone say in the chat what the diagnosis is?
Everyone's saying ovarian cancer.
Ovarian cancer, yeah, that's correct. So ovarian cancer, and just go through the risk factors. So with ovarian cancer, the more ovulations that take place, the higher the risk. Early menarche and late menopause are risk factors. So that is why early menopause was the incorrect in the answer. I think a couple of people said Lynch syndrome. It is actually a risk factor for ovarian cancer. It's more commonly associated with colorectal and endometrial cancers, but there is also an association with ovarian cancer. Other risk factors include age, so peak age is at 60, the BRCA genes, which are associated with breast cancer, obesity, oh gosh, sorry, I keep moving the slides, obesity, smoking, recurrent use of clomiphene, which is used to improve fertility, and nulliparity, not having any children, increases your risk. Protective factors include things that reduce the number of ovulations, so the combined pill, breastfeeding, and multiparity. I've only just seen this question as well about why was progesterone given in question 2. I think you're referring to the fibroid, the question on the fibroid. So the reason a GnRH agonist wasn't used in that question was because it specifically asked what could be used to help control like the heavy bleeding. So that's why I was thinking more along the lines of either a hormonal contraceptive or a tranexamic acid. And someone else has asked, it can't hormones make fibroids worse? Not that I'm aware of, possibly, but generally they are used to help control the heavy and painful periods. So, but I will look into that. I'm not sure. I didn't know that you might be correct. And sorry, a bit of a side note, I've only just noticed the Q&A box. So just quickly going through the NICE guidelines on ovarian cancer. So if a woman over 55 has ascites or a pelvic or abdominal mass, then you would make a 2-week wait referral. If they're over 50 and they have new symptoms of IBS or a change in bowel habit, abdominal bloating, early satiety, pelvic pain, weight loss, urinary symptoms, then you'd first check the CA125, and then if that was raised, you would make an urgent 2-week wait referral. So the risk of malignancy for ovarian cancer takes into account is a calculation that looks at menopausal status, ultrasound findings on the CA125, and that helps guide the further management. So moving on to question 7. So oh no, I've done it again, sorry. So a 68-year-old nulliparous woman presents to her GP, mentions to her GP, sorry, that she's noticed her urine appears pink in colour. She denies any other urinary symptoms. She also reveals that she has been getting some new white vaginal discharge, which is abnormal for her. Past medical history: hypertension, type 2 diabetes, osteoarthritis, and breast cancer. Which investigation should be requested urgently? I seem to have no longer. Oh, here we go. So, yes, everyone Most of you have answered that correctly. So the correct answer is transvaginal ultrasound scan. And what diagnosis are we worried about? Is anyone able to reply? So yeah, so that's correct. We are worried about endometrial cancer. So in this question, this lady is 68. She's not had any children. She's got some pink urine, which is most likely hematuria. She's got some new discharge, which is unusual for a 68-year-old. She's got a background of breast cancer and also high blood pressure and type 2 diabetes, which are associated with obesity, but I guess we don't know for sure if she's obese. But the risk factors for endometrial cancer include obesity, polycystic ovarian syndrome, Lynch syndrome, breast cancer, as the lady in the question had, early menarche, late menopause, and nulliparity. So endometrial cancer develops due to the presence of unopposed estrogen, which results from a lack of progesterone, which is why you get it in conditions like polycystic ovarian syndrome. And protective factors include the combined pill, having multiple children, exercise, smoking, apparently coffee and aspirin. Those ones are a bit rogue, but apparently there's been some studies that show that they are protective against endometrial cancer. Not entirely sure why. And the NICE guidelines, so that urgent 2-week rate referral if a lady over 55 presents with post-menopausal bleeding, and arrange a direct access transvaginal ultrasound scan if they're over 55 with either unexplained vaginal discharge with thrombocytosis or hematuria, or if they have visible hematuria with a low hemoglobin or thrombocytosis or high glucose. So endometrial cancer is also associated with the high platelets in the bloods, so you might see that as well as blood in the urine, and it may not always be visible, so it's always worth doing a urine dip as well. Does someone have a question? How thick? I think someone said, how thick is too thick on an ultrasound? I think it's if it's over, the lining's over 4 millimeters, if I can remember correctly.
Yeah, I think that's right.
Why does it cause hematuria? I'm not actually entirely sure why it causes hematuria. Don't know if you know, Lizzie.
So I think my understanding of it was that the patients described hematuria because the PV bleeding goes into the toilet, so they just see blood in the toilet and then they present with it. I don't know if
That's
more than that,
what I thought, to be fair. Often
that was my understanding of it. Like if a patient presents with just blood in the toilet or blood on wiping, it's hard to distinguish between the two.
Yeah, it's often difficult to know when someone says, you know, they're bleeding down below where it's actually coming from. So I think it's kind of assumed, or there's a chance that it could be from the vagina, so it's worth investigating further.
Yeah, that's exactly my understanding of it. Yeah.
And of course, like if you do, like as you guys probably know, like if you do a urine dip, for example, on someone that's on their period, it's going to have blood in it. It's kind of like the same principle. It's not actually directly coming from the urine, from the bladder. So moving on. So, gosh, I keep giving away the answers. So you see a 48-year-old lady in GP who has been amenorrheic for 2 years. She reports menopausal symptoms, including joint pains, mood swings, and sleep disturbances, but reports that the hot flushes and night sweats in particular are really bothering her. She has no history of a previous hysterectomy. She has 4 children and she is sexually active. Personal medical history includes osteoporosis, breast cancer, high blood pressure, type 2 diabetes, high cholesterol, and a hiatus hernia. Which treatment option would be the most appropriate? So we had A, citalopram, B, oral estradiol, C, a combined HRT patch, or D, norethindrone, or E, venlafaxine. So 75% of you said combined HRT patch, and a few have also said estradiol. So actually, no one has got the correct answer. This was quite a tricky one.
I think that was my fault. I may have closed it too early.
Oh gosh, only 4 people have answered. I've only just seen that. Sorry, guys. Okay, some of you might have got this right. Or I just made it really hard. But so yeah, basically, this lady is postmenopausal and she's got quite a lot of symptoms, but the ones that are really bothering her are the hot flushes and night sweats, so the vasomotor. So this vasomotor, I can't even say it, you know what I mean, symptoms. And key things to note was that she has breast cancer or has previously had breast cancer. We don't know. And she's not had her uterus removed. She's not had a hysterectomy, and she's currently sexually active. So these are all important questions to ask when you are assessing a woman for HRT. So does anyone know why she can't have the combined HRT patch? Because generally that would be first line in a woman with a uterus. However, this lady can't have it. And does anyone know why? So yeah, you guys have said breast cancer, which is correct. So I'll just, before I do, so these are the contraindications for HRT. And one of them, which is a really important one, is current, past, or suspected breast cancer. Other important contraindications to know about, I've literally just wrote them all from the NICE guidelines, and some of them are really quite obvious, like pregnancy, but like undiagnosed vaginal bleeding. So if someone's being investigated, waiting for investigations for that, shouldn't start them on HRT. Untreated endometrial hyperplasia, a known any kind of estrogen dependent cancer, previous or current VTE, unless they have been started or are on an anticoagulant, recent angina or MI, active liver disease, and thrombophilic disorder. I'm just gonna go. So if HRT is contraindicated for vasomotor symptoms, I actually only learned about this quite recently in GP. You can actually use SSRIs. So that is why citalopram, which was option A, was the correct answer. Because yeah, as I said, this lady can't have HRT. And just thought I'd mention as well, if a woman, why it's really important to ask if they've, still got a uterus and not had hysterectomy in the past, is because if they have had a hysterectomy and they no longer have a uterus, then you don't need to give them a combined preparation. You can just give them estrogen on its own, without progesterone. And the reason for this is that if you give estrogen on its own to women that do have a womb still, then there's an increased risk of endometrial cancer. Because as we said previously, endometrial cancer, you're at a higher risk if you have unimposed estrogen. So that's why you always need to give them a combined. So that's why B, which was oral estrogen, was on its own was incorrect. And just a quick point, I did mention in the thing about whether it's also really important to ask if they're sexually active. I know we sort of forget about it when women get to a certain age, but this is from the NICE guidelines. So a woman is potentially fertile for 2 years after her last menstrual period. So if she's under 50, and if she's over 50, then she's potentially fertile for 1 year after her last period. So you still need to be giving some kind of contraception if they meet this criteria. So that's why the Mirena coil is also used as a form of HRT to help with menopausal symptoms if they still need some form of contraception. But when they get to 55, you don't need to think about contraception anymore. Oh yeah, so as I've put on here, so combined hormonal contraception can be used in eligible women. Obviously, there's no contraindications if they're under 50 for release of menopausal symptoms and to prevent osteoporosis. So someone said, how is estrogen opposed if you don't have a uterus? So it's not, but if you don't have a uterus, you can't get endometrial cancer. So that's the explanation for that. I hope that makes sense. So moving on to the next question. So a 67-year-old woman complains of nocturia and urinary frequency. She often feels the need to run to the loo, and sometimes she doesn't make it in time. She has had to start wearing sanitary pads as she often leaks urine without noticing when she coughs or sneezes. She's had 3 children delivered by normal vaginal delivery. Urine dip was negative. You refer her for urodynamic testing to confirm the suspected diagnosis. In the meantime, you prescribe her a treatment to help manage her symptoms. Given the most likely diagnosis, which of the following is not used in the medical management of this condition? So is anyone able to comment on the chat what they think the diagnosis is in this case? So someone has said stress incontinence. 2 people have said stress incontinence. Okay. And someone has said urge incontinence. And then someone has said mixed. So the correct answer is mixed. So you're all right in a way. She has got elements of both stress incontinence and urinary continence. So yeah, any medications that would help with either urge or stress incontinence would be correct. So 10 of you have answered the poll, so not quite everyone. But there's quite a mix of answers here. So the correct answer is E, because all of the other medications, A, B, C, and D, can all be used to help manage incontinence. So duloxetine is used for urge incontinence, and then these other 3 medications, B, C, and D, are used for stress incontinence. And because she's got both, I guess technically you can use either of them. I guess you'd give the one that's more prominent. So just to distinguish what the difference is between the 2 types of incontinence. So stress incontinence is an involuntary leakage of urine on exertion, coughing or sneezing or exercise, and that's due to an increase in intra-abdominal pressure, and that's typically seen after childbirth. So in the question, she mentioned that she was passing urine when she was coughing or sneezing, and that she'd had 3 natural vaginal deliveries as well, normal vaginal deliveries even. So increasing her risk of that. But she also had some elements of urge incontinence, so an overactive bladder. so she had, she had urgency, she was running to the loo, she had nocturia, she's getting up in the night to go to the toilet, and she had frequency as well, she was going a lot. And on urodynamics, you'd see overactivity of the detrusor muscle. And some risk factors for this include menopause, previous hysterectomy, or pelvic surgery. So this table just summarizes how you would manage the two different types of incontinence. So firstly, obviously you'd want to try conservative measures. So in stress incontinence, this is pelvic floor muscle training. So the pelvic floor muscles which are damaged in childbirth. So exercises to help strengthen them. Also lifestyle advice. So obesity is a risk factor for stress incontinence, and so is smoking. So making those lifestyle changes is really helpful. And then also for urge incontinence, there is like bladder retraining programs, and simple things like avoiding alcohol and caffeine can help reduce the symptoms as well. So in terms of medications, which is what this question was about, so duloxetine is an NSRI, so a noradrenaline and serotonin reuptake inhibitor, and that can be used for stress incontinence. I have to be perfectly honest, I'm not entirely sure how the mechanism of how it helps, but apparently it does. And then in urge incontinence, there's lots of different medical options. So one of the most common is anticholinergic, so oxybutynin, solifenacin, tolterodine, and mirabegron, Botox injections into the bladder wall, sacral nerve stimulation, intravaginal estrogen as well can be helpful, but just to bear in mind the side effects of anticholinergics. So this is one way that you can help remember those. So can't see, can't pee, can't spit, can't shit. So I remember learning this for my exams. So they'll cause blurred vision, urinary retention. Obviously, it's got a positive effect in this scenario, but in general, urinary retention, dry mouth, and constipation. So just to be aware of those. And then also there are surgical procedures, obviously, that can be done for both of these types of incontinence. So moving on to question 10. So well done if you got that one right. Oh, so yeah, doxazosin is used for BPH, prostate, and that actually can cause, it's like an alpha receptor blocker, and that can actually cause like urinary infections and urinary incontinence in men. So it kind of goes the other way. It helps to prevent retention though in men with enlarged prostates. But so that was incorrect. So moving on to question 10. So a 32-year-old lady with type 2 diabetes, a BMI of 35, acne, and excess facial hair complains of difficulty getting pregnant despite regular sexual intercourse with a partner for the past 18 months. Given the most likely diagnosis, what blood test results would you find in this condition? So a bit of a mix here. So there's kind of a split between A and B at the moment. So the correct answer, so well done to the 6 of you that got this right, because it's quite a tricky question actually. So the correct answer is A. So firstly, what is the diagnosis? I think we should cover that to begin with. What is the diagnosis? What do we think obviously we don't know for sure, but based on the history, what do we think? So yeah, 2 of you have said PCOS, so that's correct. So in polycystic ovarian syndrome, you get high testosterone and your progesterone would be low because you're not ovulating. And we'll cover a bit more about PCOS and what it is, but basically you don't have normal ovulation, so progesterone will be low. LH will be high, but FSH will be normal. So it's important to remember that out of everything from sort of the blood tests in PCOS, I'd probably remember that the LH to FSH ratio will be high. That's probably like key thing to remember from this. And sex hormone binding globulin will be low because it will be suppressed by the high insulin levels. And you have high insulin levels because you're resistant to insulin if you have PCOS. This will probably make a bit more sense when I go through what PCOS actually is, for those of you that don't know or can't remember. So this table is how PCOS is diagnosed. So you use the Rotterdam criteria, and you need at least 2 of the 3 to make a diagnosis. So either oligo-ovulation, which means irregular ovulation, or anovulation, which means no ovulation at all. And that will be characterized by having irregular or absent menstrual periods, so amenorrhea or oligomenorrhea. It'll present with hyperandrogenism, so hirsutism, as you can see in the photo there, so excess facial hair, and also acne will be a sign of hyperandrogenism. And finally, you'll see polycystic ovaries on the ultrasound scan. So in order to actually fit the diagnosis of PCOS, you need at least 12 developing follicles to be seen in 1 ovary, or a total ovarian volume over 10 centimeters. And you may see, this may come up in like exams, I don't know, but you may see the follicles around the periphery of the ovary on the ultrasound in like a string of pearls arrangement. So if you see that in a question, you'll know it's PCOS. If they've just say got the polycystic ovaries without the other thing, then the diagnosis is polycystic ovaries, not polycystic ovarian syndrome. And can anyone tell me what the name of the sign is? This, like in the first photo here, this like dark, thick patches on the skin, which you normally get in the neck, on the axilla, quite commonly. Does anyone, and you get it in obesity, oh yeah, someone said. So yeah, this is called acanthosis nigrans. And that occurs in PCOS due to insulin resistance. So well done. Question 11, what of the I should say, so that's really poor grammar. Which of the following would not be an appropriate management strategy to help improve her chances of becoming pregnant? So there's A, clomiphene, B, orlistat, C, sitagliptin, D, ovarian drilling, or E, letrozole. So just remember okay. So quite a lot of you guys have said letrozole. Half of you have said letrozole. Quite a few have also said orlistat. There's quite a mix. So the correct answer was actually C. So sitagliptin is generally not used in PCOS. Metformin is. And metformin would be correct if that was on there, but sitagliptins that's used in type 2 diabetes, not really known to help improve fertility in PCOS. But all these other ones are correct. So in terms of managing infertility, so weight loss is the best method. And this can be helped by orlistat, which is a lipase inhibitor, which reduces fat absorption. So that's why orlistat is correct. Clomiphene is commonly used for fertility in PCOS. It helps stimulate the release of gonadotropin releasing hormones to get more LH and FSH. Laparoscopic ovarian drilling, it sounds very dramatic. This is basically when diathermy is used to puncture holes in the ovaries, and this can be used to help improve fertility. Letrozole is another way to help improve infertility. So this is a selective aromatase inhibitor, and it has the effect of increasing estrogen, which leads to there being more FSH to stimulate ovulation. And metformin generally helps improve insulin sensitivity. So generally you're going to have lower levels of insulin, you'll have higher sex hormone binding globulin. Generally tends to make periods more regular to help aid ovulation. And of course, IVF is also commonly used if all else fails, to help improve, to help allow people with PCOS to get pregnant. So question 12. A mother brings her 16-year-old daughter to the GP with concerns that she's yet to start her periods. Which of the following is not a possible cause of this presentation? So there's A, Kalman syndrome, B, Turner's syndrome, C, congenital adrenal hyperplasia, D, Asherman syndrome, or E, androgen insensitivity syndrome. So you've all answered. So 50% have said D, which was the correct answer. Quite a lot of you have also said A, but I'll go through why. A is actually a cause. So basically this question was about primary amenorrhea. So the definition of primary amenorrhea is no periods by the age of 13 when there's no other evidence of pubertal development, or by the age of 15 where there are other signs of puberty. So in this case, the patient was 15 and 16 even, they're yet to start their periods. So Kalman syndrome is a cause of this. So this is where there is a deficiency of LH and FSH. So hypogonadotrophic hypogonadism. So that means puberty fails to start, and that's associated with a loss of sense of smell, which is a really random fact, but something to remember. Congenital adrenal hyperplasia is 21 hydroxylase enzyme deficiency, and that causes low levels of cortisol and aldosterone, which leads to a overproduction of androgens, so male sex hormones, so periods won't start. Also, again, androgen insensitivity syndrome tissues unable to respond to androgens, so they will have a female phenotype other than internal male organs. And finally, Turner syndrome, and this is where there is LH and FSH, but there's a failure to respond to it. So this is hypergonadotrophic hypergonadism. So, and just quickly, I thought I'd mention about, so that's why Asherman syndrome is a cause of secondary amenorrhea. So this is defined as the cessation of menstruation for 3 to 6 months in women with previously normal and regular menses. And in this case, the 16-year-old had never started her periods. So that's why she couldn't possibly have Asherman syndrome, which is caused by damage to the uterus, which is normally through procedures like pelvic surgery and D&C in pregnancy. And that leads to adhesions forming, so periods stop. And these are just some other causes of secondary amenorrhea. So the physiological ones like pregnancy and menopause, thyroid disease, pituitary tumors causing hyperlactin, premature ovarian failure, which is when menopause happens under 40. I've just put some causes of premature ovarian failure. I won't go into it now because I'm overrunning, and you guys will get the slides after anyway, so you can have a look after. And Sheehan syndrome may come up in exams and things as well. That's a complication of postpartum hemorrhage. And that's when the drop in circulating blood volume leads to avascular necrosis of the pituitary gland, which is obviously where LH and FSH is produced. So you'll no longer have periods in that case. Yep, so moving on, question 13. So a 50-year-old, someone's asked, sorry, I've just a quick one. Someone's asked, what's the feedback loop between SHBG and insulin? All I know is that high insulin levels suppress sex hormone binding globulin. I'm not entirely sure why. But yeah, sorry.
I've just been looking it up. I think it's quite a complex.
I don't know.
Complex. I don't think it's anything you'd be tested on. If I get any more information, I'll pop it in that answer.
I think that's quite advanced knowledge. I don't think you'd need to know that for finals or anything. But yeah, a 50-year-old lady. So sorry, moving back to question 13. A 50-year-old lady attends her GP with abdominal discomfort and bloating. She also mentions that she's had a cough and felt quite breathless for the past 6 weeks. On examination, the abdomen is distended and there is shifting dullness on percussion. Chest examination, there is normal air entry bilaterally, no crackles or wheeze, but stony dull percussion at the bases. You arrange a pelvic ultrasound scan which reveals a large, solid hypoechoic mass in the right ovary. What is this mass most likely to represent? So A, a germ cell tumour, B, a fibroma, C, a serous cystadenoma, D, a Brenner tumour, or E, a follicular cyst. Have we got a poll for this one?
Sorry, there you go.
Oh gosh, sorry, I can see it now. So this is quite, well, I think it's quite a tricky question anyway. I don't know if you guys find it hard. And I think if you put C, okay, so the correct answer was actually B, but I think if you put C, I can completely understand why you might have thought it was C. So the correct answer was B, because in this case, this lady has something called Meg's syndrome, which is when there is a triad of a benign ovarian fibroma, which presents with ascites and a pleural effusion. So from the symptoms and the examination findings, the idea was that you guys would recognize that she has ascites, as she had a distended abdomen with shifting dullness. And hopefully you guys would have recognized that she had a pleural effusion, or that she might have something wrong with her lungs, because she had, it's quite vague, but a cough and breathlessness, and she had stony, dull percussion at bases. But yeah, this is quite a tricky one. The reason I said why you might have thought C was correct is because serous cystadenoma is the most common type of malignant ovarian tumor. So that's why you might have thought that. However, in this case, the patient had Meg syndrome, so she had a fibroma. So this slide just tells you a bit more about the different types of ovarian tumors. I don't feel like I need to go into it that much. Yeah, and dermoid cysts. I think one or two of you might have put dermoid cyst, but generally these are more common in younger women, and quite often in pregnancy they may occur. Yeah, so moving on to question 14. So a 79-year-old lady complains of itchiness down below and bumpy lumps on the vagina, which she noticed several months ago. She denies any PV bleeding or discharge. On examination, you can see atrophic white lesions on the vulva with fusion of the clitoral head. There are raised papules and plaques. What are your next steps? So, quite a mix here. So 4 of you have answered correctly. So the correct answer was B. So clobetasol propionate, which is a potent steroid. So does anyone know what the diagnosis is in this case? So she's complaining of itchiness, and there's atrophic white lesions on the vulva, and she's 79. So someone has said, oh, quite a lot of you have said she's got lichen sclerosis. Correct. So she's got lichen sclerosis, which is treated with steroids. So fair enough if you put C, hydrocortisone cream. However, it's treated with a potent steroid cream as opposed to a weak one. Like hydrocortisone is very weak. And generally it's treated with quite a strong potent steroid. Just quickly to go through the other options. So A, estrogel, that would be used for basically like simple atrophic vaginitis, so itchiness, dryness. However, because she's got these typical atrophic white lesions and changes suggesting lichen sclerosis, that's why you'd need to use a steroid instead. Generally you wouldn't use an oral steroid, you just use a cream. And yes, some people have said 2-week wait for an ultrasound, but that wouldn't be necessary. So just a bit about what lichen sclerosis is. So it's a chronic inflammatory skin disease of the anogenital region. There's generally peaks in prepubescent girls and then again in postmenopausal women. Risk factors include family history and other autoimmune disease. So potent topical steroids are used, and they're generally used long term. So to begin with, they'll be given for like 4 weeks, and then they'll have a weaning regime as well. And the steroids, as well as help with the itching and the inflammation, they also help to reduce the risk of malignancy. So finally, question 15. So what complication is she at risk of? So if you just put your answer in the poll. And someone has asked, how strong is clobetasol compared to Umivate and Betnovate? So on the top of my head, I think Betnovate is also potent.
So clobetasol is the same as Dermavate, which is the strongest steroid. Umivate is the second, so it's hydrocortisone, then Umivate, then Betnovate, and then Dermavate at the top. But Dermavate is another name for clobetasol appropriate.
There you go. That's a good explanation. There are like, if you want like to Google it, there are like steroid ladders which are used quite a lot in GP and stuff as well, which I always have to look at, which have like the different steroids and the potencies, which is quite useful. But thank you, Lizzie, for explaining. Do we have a poll for this one? Question 15.
Sorry, one sec.
No, it's okay. Oh, someone said you need PPI cover. No, you don't, because they're not systemic steroids. If they were oral, definitely, but because they're because it's just a steroid cream, you don't need a PPI. That's a very good question. So most of you guys have put A. 64% have said A. I think a couple more need to answer, but and quite a lot have also said C. So it's a toss-up between okay, no one else has said any of the other options. So it's a toss-up between you guys definitely all know that she's at risk of a vulval cancer. However, which type is the difficulty in knowing. So the correct answer was A, squamous cell carcinoma of the vulva. So vulval cancer, 90% are squamous cell carcinomas. So for that fact alone, I think is why she's at increased risk. And the main risk factors for this are HPV and also inflammatory skin conditions like lichen sclerosis, as we've mentioned. Symptoms can include pruritus, burning, soreness, bleeding, pain, and you may actually see a lump. And it's diagnosed via Key's punch biopsy. And so if they're, so this photo, sorry that these photos are really graphic, but this photo shows of squamous cell vulval carcinoma. And sometimes in lichen sclerosis, if it's really quite advanced, they might have quite thick like plaques. And you might not be sure if that is actually a vulval cancer. So you might need to refer them to have a biopsy to make sure it's not become cancerous. But generally, if you treat the lichen sclerosis with steroids, then you can reduce the risk of them developing cancer. But yeah, well done. You guys basically all knew that it's just what type of cancer, which is always tricky to know. So yeah, that's it, guys. Sorry I went on a bit at the end and I had to rush through the slides, but if you could fill in the feedback, that would be really helpful. And then we can get the slides sent out so you can read through the information at your own pace. Yeah, I hope that was helpful.
Thank you so much, Katie. That was really, really helpful. Really good questions, and hopefully that was useful for everyone. I've put the feedback link in the chat. I'll just post it again in a second, in case anyone's not got it. And yeah, that was really, really useful. Thank you so much, Katie. There's just one question that I think I missed, and you probably had it on your slide, so I didn't try and repeat it. So there's a question that says, can you repeat when you refer for ovarian cancer? I just wondered if we could pop back to that slide just as you finish.
Yeah. So I'll just go back. I think I was missing in that slide the age. So I will add the age when I send out these slides. I think I forgot to put in there that the 2-week rate referral is if they're over 50 with ascites or a pelvic or abdominal mass. And then the and so if physical examination reveals ascites or a mass, you just, in a lady over 50, you just refer them for an ultrasound. You don't need to check CA125 even. But then if they've got some of these more vague symptoms, like which can be associated with lots of different things like bloating, weight loss, urinary symptoms, then generally you'd check the CA125 first, which is, it's not a very specific test because it can be raised in other conditions, like even like endometriosis and things can cause a raised CA125, but it does support the diagnosis if you're not sure if it could be ovarian cancer. So if they've got any of these vague kind of symptoms, and they've got and if they're a lady over 50, then you should arrange a blood test for them. Does that make sense, whoever asked?
Lovely, that's
cool. Does anyone have any more questions at all? I'll go back to the end.
That's great. Yeah, I don't think there's any more questions. Thank you so much, Katie. Really appreciate you doing that session.
Okay, no problem. I hope everyone has a nice evening, what's left of it.
Thank you.
Bye. Thank you.
Bye.